All right, guys, we're ready for the 2:15 session here. Before we get started, before I turn this over to Derek, welcome back. We got this session and one more after this. So if you haven't registered for the last session, make sure you do so. We'll also put that in the comments at the end. All of these are going up on our YouTube channel, so make sure you check that out if you haven't had a chance yet. And just give me just a sec. We'll get Derek's presentation up here and we'll get going.
Okay. All right. Well, thank you everybody for joining my talk here about non-invasive positive pressure ventilation. My name is Derek. I'm a respiratory therapist. Let me try to get to the next slide here. Yeah.
Nope.
Just one moment here.
Let's try this. Nope.
Space bar. Nope. Might need to give Sean over here.
Derek is our first session that we're presenting with him in the room.
Yeah.
So now we have to figure out the reverse technology. So stand by. We will get his presentation forwarded momentarily.
Next. No. There we go. Well, I'll just have to do that. Okay. All righty. Well, so before we begin, I just wanted to introduce myself. Like I said, my name is Derek. I'm a registered respiratory therapist. I've been a therapist for about 13 years. I made this slide for the conference that was supposed to be last year, so didn't update that part. But I've got a lot of experience. I've worked mostly in the state of Colorado. One of the hospitals over there, Lutheran Medical Center, which was about a 250, 280 bed hospital. And then I worked at University of Colorado Hospital, which was a massive 1,000-bed hospital right outside of Denver. The picture actually right there behind you, that is the facility. That's a zoomed in picture of it. 2 inpatient towers that are both 12 stories each. So just huge hospital, a lot of experience, a lot of working with non-invasive ventilation, which we'll get to in a sec. I was a clinical educator as well for one of the local respiratory schools there. And the name of that was Pima Medical Institute. But currently, I work for St. Anthony Hospital here in Pendleton, Oregon. So I'm sure I've seen a few of you guys. I'm terrible with names though, so I know your face, but I don't probably know your name. But well, and then now that masks are a thing, and now I got to kind of get used to what your foreheads look like. But anywho, so we're gonna go ahead and have a few objectives here that we're gonna achieve with this presentation. First, we're gonna define what non-invasive ventilation is, which is kind of have these subcategories of BiPAP and CPAP. We're gonna talk about some of the indications, contraindications. We're gonna talk about the benefits of non-invasive ventilation, why you would do that versus, intubating or whatnot. And then just a quick tutorial about procedural application, troubleshooting, and then what we'll do after that, because I kept this fairly basic, but so what we'll do after that is I have a few case scenarios that we'll talk about. And if I had an audience, I would have some participation on that slide as far as, what would the diagnosis be? What should we do, intubate or non-invasive or BiPAP, CPAP? but I'll still kind of talk through it, and you know, we'll do the best we can there. So I do have a question slide at the end as well, so just we'll just wait for that the questions there. Before we look at these waveforms, I'm going to just kind of have a few definitions that I wanted to talk about, and then I'll kind of refer to these waveforms. So when I'm saying non-invasive ventilation, what I'm pretty much referring to is just any ventilation or mechanical ventilation delivery to the lungs that is not requiring an artificial airway like an endotracheal tube or a tracheostomy tube. So it's just basically giving ventilation to a patient that is not involving invasive procedures. So that's kind of an umbrella definition. Underneath that umbrella definition, there's two subcategories, CPAP and BiPAP. CPAP is basically one continuous pressure, that's a positive pressure to the airway during the respiratory cycle, so both during an inspiratory breath and an expiratory breath. Over on the waveforms here, that very first one on the left is a normal breathing one. So basically that's just kind of showing you somebody who's breathing normally. They're able to pull whatever volume of breath they want, and they're able to breathe as fast or as slow as they want. But as you can see, their expiratory breath goes down and hits that baseline there. So whereas CPAP, it's essentially mimicking their own breathing still. So they're able to pull whatever volume they want, whatever respiratory rate, or how fast or how slow they want. But as you can see, it doesn't reach that baseline. It's gonna stop right wherever our CPAP number that we decide to choose for them is. So they'll be able to breathe as high as they want, but when they go down to that expiratory phase, they're going to breathe down to the pressure that we set. And I'll talk more about just very basic settings that we would do. Whereas BiPAP, BiPAP refers to two pressures, or basically bi-level positive airway pressure that essentially is going to cycle between an inspiratory pressure and an expiratory pressure. So if we look over at the waveform again, that very far right one, you'll see there's an EPAP, or your expiratory pressure, that is kind of their starting baseline. And then when the machine senses that the patient is going to start breathing inward, it'll kick to this secondary pressure that we set, or this inspiratory pressure. So it's going to aid their breath up to that second pressure. Once again the patient is finished with that inspiratory cycle, then again the machine will back down to that lower pressure again. So as you can see, we're dealing with two pressures there. And so what's nice about BiPAP is for someone who is needing that air, that ventilation, that breathing, they say they can't breathe, I need air. This is going to help them really like feel as though they are getting that breath. CPAP, on the other hand, will do that a little bit, but CPAP kind of helps just open those lungs so that way they can ventilate that way. So it definitely helps with oxygenation, things like that. So I hope that kind of clarifies a little bit better as to what the difference between CPAP and BiPAP is. So some of the settings, and I referred to a respiratory book. I guess I didn't put that reference on here, but a good starting point of CPAP would be roughly 5 to 10 centimeters of water pressure. Whereas BiPAP, you're dealing with those two pressures. So the first pressure, your EPAP, would be that about 5 to 8 centimeters of water pressure. And then that second pressure, the IPAP, would be about 10 to 12. And that's just a general starting area. What you would do from there is just assess your patient, get vital signs, titrate up or down till it's tolerable, but you're also achieving, a good physiological response from the patient. And if I know on the rig, you guys mostly work with CPAP, and you have that easy flow, I believe it's called. I'm not quite sure, but it's deals with an oxygen flow that you can kind of increase to achieve a certain pressure. So just try to start a little bit on the low end and work your way up, because it's not going to be natural. It's not going to feel very comfortable. And you know that you did too high of a pressure if your patient looks like this. So this would be so much better if you guys were here. People would be high-fiving right now, like laughing, running to the bathroom. But basically CPAP, you know you're doing it wrong if the face is a little bit too pressurized like that one is. Okay, so we'll go ahead, we'll start talking about some of the benefits. Obviously, one of the biggest benefits is you're going to help decrease that patient's work of breathing. And the way you're going to do that is by essentially increasing their lung compliance, or if their lung is collapsed due to atelectasis or something going on, you can pop those alveoli open, that airway open, and allow them to be able to ventilate and oxygenate. And so then in turn, of course, the patient's going to benefit from that machine. They're going to breathe better. Overcoming your intrinsic PEEP, so same thing, you're just kind of decreasing the dead space of the airway, so in that way they're not fighting against that, as they can achieve like a better breath now. And kind of what I mentioned, with that airway open, then you're going to have this better gas exchange, so you're going to be able to remove more CO2. You're going to be able to increase your oxygen consumption. You're going to decrease your VQ mismatch, or your ventilation of perfusion, by opening up that airway. And one of the biggest benefits, of course, is it's less invasive than having to intubate somebody. So you're going to be able to hopefully prevent a large medical bill by intubating somebody, placing them on the ventilator. So yeah, there's plenty more benefits. Those are just a few that I just wanted to kind of capture there. So what are some of the indications here? I'm going to talk about that X-ray here just because it was pretty cool looking here in a sec. But so obviously, if somebody has an increased work of breathing, they're only speaking one word sentences, they're pursed-lip breathing, they're using a lot of accessory muscle, tripoding, I mean, whatever, you know what they look like when they are, working hard to breathe. If somebody's in a hypercapnic or a hypoxic respiratory failure, or both, that obviously is an indication to trial that out, see if we can reverse those processes there. Patients that have COPD, I keep doing that, or patients with CHF, asthma, pulmonary edema patients, all those things are going to help, if they're in an exacerbative state, that's going to help them kind of achieve a better breath, better ventilation. ARDS patients, or acute respiratory distress syndrome patients, and of course patients with OSA, those are the patients that just need it for when they're sleeping, keeps their airway open. But I put this X-ray on here just because I actually experienced this in my last hospital at University of Colorado Hospital, and well, it will be the left side of your screen, but the right side of the lung, you could tell that this is a COPD patient just based off of how long this lung is. COPD patients tend to trap air a lot, and so they over time cause them to be very hyperinflated. And you can tell because there's the angles at the bottom of the lung there are supposed to be a lot sharper than those ones are, so those are pretty pushed down. So that being said, that this is a COPD patient, that on your right side of the screen, or the patient's left upper lung, you can see all those like little circles there. And what that is ping pong balls. And back in the day, a long time ago, I don't believe they do this anymore. I haven't seen it at least, but they used to remove lung. So this must have been a left upper lobectomy. And they would put ping pong balls in the chest cavity to prevent it from collapsing down. And I actually saw this on a patient. It was their whole entire right lung had just pure ping pong balls everywhere, which I thought was kind of interesting. But yeah, so we're going to talk about, so that was the indications. We're going to talk about contraindications next. So obviously you don't want to put somebody on a machine that's going to blow air into their face if they are vomiting. And that's obviously going to cause them to possibly inhale that into their lungs or aspirate. And that's going to be a whole mess of a problem there. So definitely don't do that. Kind of what the previous presentation was mentioning, if you guys joined that one, patients with pneumothoraxes, you don't want to be putting them on a machine that's going to push air into that lung, because it's just going to seep out into that chest cavity and cause the lung to get worse and worse. If somebody has facial trauma, you don't want to be placing this machine on them, because the mask is just going to cause that facial trauma to be worse. There's going to be leaks. I mean, it's just going to be a huge mess. If somebody's unresponsive, you don't want to be placing them on, because we don't know if that patient is protecting their airway. So don't be putting them on that as well. If somebody's having a cardiac or a respiratory arrest, of course, that is much more severe than what these machines are able to do. So don't be doing that. Well, kind of what I mentioned a little bit ago. So if somebody's not able to protect their airway, we won't want to be putting them on that machine there. And somebody who's hypotensive is actually a contraindication, because you're putting positive pressure into that chest cavity. And so if somebody has a really low, blood pressure, your lungs are going to squeeze onto that heart, which is going to cause them to have even a worse preload, and you're basically going to just knock them out. So don't place it on somebody who is hypotensive as well. I'm sure there's plenty more there. Again, I just kind of went through some of the ones that were kind of an obvious ones not to do. So real briefly, I'll just talk about the procedure. I pertained this particular slide to just it maybe not be as effective doing this full-on procedure in the rig, because you just want to hurry up and get them on it. But the textbook is you want to go ahead and prepare all the equipment that you're going to need. Because obviously we have plenty of time when we're out and about, driving around, picking people up who are breathing bad. We're going to want to tell the patient that what we're going to do, we're going to be placing you on this machine. It's going to help you breathe, blah, blah, blah. In theory, you'd want to have them up, sitting in a more upright position or high Fowler's, semi-Fowler's position. And again, that's just kind of so that way we prevent them from possibly having air go into their stomach and then they vomit, and then, you know, then we have a whole nother problem. You're going to turn your device on, make sure that it's working and there's actual flow going there. And then you're going to apply the mask. I noticed most of the masks are what this one is here in this picture, which is called a full face mask. And so you just want to apply it to where the top of the mask is at the bridge of the nose. And then the lower portion of the mask is going to just kind of sit in between that lower lip there and the chin. So right in between there. And then of course you got to tighten up the straps, make sure that it's pretty snug, but don't get it too tight there, because then you're going to cause, you know, breakdown of the skin to the face over time. So just snug enough that they're able to get that breath, but there's not too much leaks going on. And then you are going to want to start your pressures off in that range that I had mentioned earlier. In this case, if we were doing CPAPs, it would be 5 to 10 centimeters of water pressure. With BiPAP, you would want to increase your, well, BiPAP and CPAP, you want to increase your pressures about every 2 to 5 centimeters every couple of minutes until you can kind of see a therapeutic response from your patient. Again, checking your vital signs, making sure all of those are looking better. But you don't want to go too high of a pressure. Again, from my slide earlier with the ladies having her face blown off by by all that pressure there. So they one of the references that I mentioned at the end of my slide says to not exceed over 20 to 23 centimeters of water pressure. So, and that's pretty high. So definitely don't get there. You want to check for air leaks, of course. So once you get those straps done, check for air leaks, make sure, you know, it's okay to have a small leak, but you don't want to go, you know, have a massive one, because then the patient's really not going to be getting a full effect of this machine. And so you'll just, you know, assess for those things, tighten the straps if you need to. Patients with like massive facial hair, there's definitely it's a struggle to get those ones because there's just a lot of leak there, but do as best you can though. And then of course you want to obtain vital signs, check your patient, make sure everything's good. So when you're all said and done, the picture right there should be roughly what it looks like. Or it could look like this guy right here, Bane from Batman. Patients be like, it's really uncomfortable. Okay, well, you're breathing better, right? So do you think, I'm curious if they got their inspiration for this guy from going to the hospital and seeing somebody on BiPAP. They were like, hey, that looks like that would be a cool supervillain mask. Anywho, again, that would have been so much better if you guys were here high-fiving, laughing. People would have had to leave. Okay. Let's see here. So troubleshooting, I talked a little bit about this, but, and I tried to gear this towards what the CPAP devices that you guys use versus what we would do in hospital, because our machines tell us a lot about what's going on, and we can kind of troubleshoot differently than what you guys have for out and about. So if you have a low pressure or you're just unable to maintain your pressures from your mask or your device, one of the things you could just check is to make sure that your oxygen levels are appropriate. You know, you don't have like a dry tank or anything. That one's kind of pretty self-explanatory. Just make sure it's on. Sometimes it could be off or something too, even. And then same thing as earlier, if you want to just adjust that mask, tighten the straps a little bit just to make sure that you're not having this low pressure because of a leak. If you have a high pressure, one of the probable causes or one of the things that could possibly be going on is the patient has just like a mass amount of secretions, or their airway is blocked for whatever reason. So you could just try suctioning them, repositioning them. Like I said, they're in theory, they're supposed to be sitting pretty high up there in a seated position. So maybe reposition them. Just check to make sure that the settings that you have or the oxygen flow is appropriate. And then the leak issue, which I keep mentioning, that seems to be the most common one for me, at least, is just there's a leak in that mask. And so, of course, you want to just check to make sure that you have a proper seal. Or yeah, maybe you're using a smaller mask or something, or a bigger mask, and it's just need to switch out masks. Yeah, so that was mostly the presentation portion of it. And I hope I kind of gave a little bit better understanding as far as what the differences of the BiPAP and CPAP are. And, you know, just kind of all those indications, contraindications, things like that. But so I got a few case studies we'll just run through real quick, just because it's kind of fun. First patient here that we have, though, is going to be a 67-year-old male. And you get called saying that they're short of breath. So you go over there to their house and you start obtaining some information. They come to find out they have a history of cardiovascular disease. And the patient's wife mentioned that his breathing has been getting worse over the past few hours, but he did take that water pill, though. But you notice he's diaphoretic, he's speaking in short sentences, and you take a listen to the lungs, and you just kind of are hearing a bunch of crackling throughout. You obtain some vital signs, and you got a heart rate of 120 beats per minute, respiratory rate's 32, you know, blood pressure 150 over 95, and because you guys are super stellar, you have your own ABG kit and iStat machine to run it, and so you happen to just, well, let's just get an ABG while we're here, which is phenomenal. I appreciate that, that's for sure. And so you notice here that the pH is 7.48, the PaCO2 is 31, the PaO2 is 61, and the bicarb or the HCO3 is 24. So with all of that said, what is the patient's diagnosis? So I'm gonna go ahead and just answer all this stuff just because it's gonna be kind of hard to have audience participation. But this patient's obviously more in a cardiac type event versus something respiratory related going on. And you can tell that because you heard a bunch of crackling in the lungs versus kind of wheezing or just diminished tight airway. You can also tell because he's breathing a little fast, but the CO2 is quite low for someone who would be in like a more respiratory issue. And so they're just having this low oxygen type level, just given the fact that you have PaO2 of 61. So this person is in a cardiogenic pulmonary edema. And so would we intubate this patient or would we place them on a CPAP or a BiPAP? And I don't believe this patient needs intubated. His vital signs are not that bad. He is speaking in short sentences versus one word or no at all sentences. So I wouldn't intubate this person. I would definitely try non-invasive ventilation. And more specifically, this guy would actually do pretty good on CPAP versus BiPAP. And the reason is because the CPAP is going to just provide this positive pressure that's going to push that pulmonary edema, that fluid out of the lungs and back into the vasculature. And with that fluid out of the lungs at that point, that person should start breathing better right away. I've actually seen it happen almost instantly. I put them on there and they're like, oh yeah, that I can feel so much better now. But don't take them back off, because you still want to give that pressure some time to officially get all that out, and reverse their disease process that's going on with other things like Lasix or something else too. So this person would be good for CPAP. And by pushing that fluid out, they're already ventilating, so it'll actually just help with their oxygenation issues and their shortness of breath. So yeah, that's the first one there. So we got one more. I'm talking pretty fast there. My time is pretty quick. But so this next person is a 61-year-old female who for the past 3 days has been getting worsening shortness of breath, and only able to speak one-word sentences. When you show up, you notice that the person smells like an ashtray. And so you ask, and come to find out she has a pretty significant smoking history. You've given multiple nebulizer treatments and have noticed there's just not been any relief from that. The breath sounds are just wheezy throughout, probably audible as well. You probably didn't really even need to use a stethoscope for this particular person. But so anywho, you hook them up, you get some vital signs, and you notice that her heart rate is 140 beats per minute. She's breathing at 42 breaths a minute. On room air, her oxygen saturation was 71%. Blood pressure 147/86, and you went ahead and had an end tidal cannula sitting by, so you just put that on her and noticed that her end tidal CO2 was 68. So what is the diagnosis of this patient? This one, obvious, this is more respiratory related issue going on. This person's probably in a COPD exacerbation, and she probably has COPD because she smoked a bunch. And but anywho, and then she's been getting worse over the past several days. So you know that she's not, well, there goes that joke. that probably was more funny than the actual joke's gonna be. But anywho, so this person is a COPD exacerbation. So should we intubate or should we try non-invasive ventilation? This one was going to be a good one for like a debate, an audience debate, because this one's kind of can be both. I, as an RT, would probably try to shoot for placing them on BiPAP though, and see if we can turn them around. Give them a couple of hours and see if we can turn them around on that BiPAP. But this person is pretty bad. I mean, she's been worsening for 3 days. Nebs aren't doing anything. Her CO2 is pretty high, and that's on an end tidal cannula. There's a huge difference between end tidal and then your actual partial pressure of CO2 in your blood. And so usually end tidals read higher or lower than what your actual blood CO2 is. So 68 on the end tidal, she's probably even higher than that if we were to obtain an ABG. So she's pretty bad, to the point where I guess it would be based off of what you guys see while you're out there in the clinical situation there. So you could intubate them, but I always try to shoot for working on preventing intubating, especially a COPDer, because they're a lot they are hard to get off of the ventilator once you've placed them on. So I would shoot for BiPAP first, give them a couple hours, run some more tests and maybe more nebs, and then at that point, if they are still looking pretty bad, you would intubate. But regardless, if you have a patient who just seems to never want to wear their machine, they keep taking it off, I always just tell them, well, you can either put BiPAP back on your face or you're going to get the tube again. So, so with that being said, that was pretty much the non-invasive ventilation there. I'm going to go ahead and open this up for questions.
So Derek, I'm going to ask you a question on that last one. Knowing that most of us don't carry BiPAP,
Yeah.
would you CPAP that COPD patient versus intubate?
Oh, yeah.
What's the effects of CPAP on COPD or possible consequences, or any, if any?
Yeah, that's a great question. So even CPAP has been shown to still minimize or decrease their risk, their increased work of breathing. And so I do think that if you are able to get them on that machine pretty quickly, it's probably, you might even be able to do it faster than getting all your RSI drugs and getting your intubation kits. So I still feel that putting them on CPAP, maybe doing a little bit higher of a pressure to really try to open up those collapsed lung that's kind of going on with her COPD process, you still will probably be able to see some benefits from that patient. And then just hit that pedal to the metal and get them to the hospital so we can kind of go from there. I mean, usually when I get a call like that, that's what's most of the time, that's what I've noticed. The patients comes in on that CPAP. I immediately put them on my machine. I put them on BiPAP, of course, at that point. But I do think that it still benefit the patient to try that CPAP.
All right, Derek, we have another question. What are some considerations around COVID when we're thinking about CPAP and BiPAP?
Yeah, so of course this kind of threw a wrench in our processes here. So because COVID is a respiratory virus, it's going to cause a lot of increased aerosol in the air by having somebody on BiPAP or CPAP. So there are viral filters that will filter out a lot of that virus. I don't know the exact percentage of what it filters out, but it's a pretty high percentage. So in the hospital setting, that's what we do. We have them on a viral filter that will kind of filter that out. And then of course, even with that, we still wear our N95 masks to help filter out some more of that. And depending on which hospital you're working for, they may or may not recommend you wearing, the full-on PPE, such as like your gowns and gloves and everything like that. But I've been hearing other hospitals don't wear gowns anymore. They just the N95, eye protection, and then that viral filter is kind of what they've been doing.
We had one person ask, how do you deliver BiPAP? What device do you use?
I don't know what devices that you guys have in your rig. The one that I've seen, I want to say it's called like an Easy Flow or something like that. And that one that one does not deliver BiPAP, but there are other devices out there that do deliver BiPAP. I mean, there's transport ventilators even have a non-invasive mode where you can switch them to BiPAP or CPAP. So if you happen to have a transport ventilator on board with you, you can switch that from an invasive mode to a non-invasive mode, and then on there we'll have your BiPAP and CPAP settings that you can do from there.
Yeah, Easy Flow now makes a BiPAP device separate from the CPAP device that pre-hospital can purchase as well. It's also based on oxygen flow, but two separate.
And then we had another question. What is your experience with end tidal CO2 readings taken from a CPAP device? Is it accurate when it's taken with a high pressure
Oh, that's a really good question. Yeah, I should have mentioned that in my PowerPoint. Yeah, so generally they frown upon putting somebody on end tidal while the machine is on, and it's because the machine is going to have this just continuous flow going through, and so it's actually kind of washing out your end tidal readings. And so therefore you don't really want to do that. Now, have I seen that? Oh yes, I've seen people cutting stuff. Okay, don't, we cannot be cutting our equipment. There's a reason why it is the way it is, okay? But I have seen people cut it, place it in the mass, things like that, and you will get a reading, but it's not going to be accurate at all. I wouldn't trust that at that point. So with somebody who's on a CPAP or BiPAP and they're going to be on there pretty continuously, your best bet is to shoot for getting an arterial blood gas and adjusting your settings from there. You may even have to repeat that process a couple times, get a gas, then adjust your settings, get another gas later, you know, kind of go from there.
And then with COVID, we're seeing more proning of patients. Are there any patients that are being proned that are on CPAP or BiPAP and thinking out of hospital for long transports?
Well, I guess I can only speak for what I currently see, and I don't see anyone that is on BiPAP or CPAP while proning. So I know that they do prone them while they're intubated, and it's that mask is just so huge that I don't really know if I would recommend doing that, just because there's just going to be a massive amount of uncomfortable factor for the patient, as well as breakdown of that facial tissue. I mean, we have some pretty thin skin there, so I mean that's just going to cause a lot more problems. So for me, what I've seen is just they're either intubated or their COVID is they're not, their lungs aren't too bad, so they're able to just self-prone. If we did have a patient that wasn't necessarily needing intubated, I would even shoot more for trying to do something like a high flow device for delivering oxygen to the patient versus that CPAP BiPAP, just because that's going to be less equipment on their face while they're in that prone position.
All right, and we had somebody ask, what is proning? So that's not always something you see out of the hospital.
Yeah, okay. Well, so proning is when you have a patient that you move from their back, laying on their back, and you're going to have them lay on their belly, or some patients just their sides. But what you're doing when you put somebody in prone position or have them lay on their belly is you are allowing for more lung expansion, because they're not like laying down on their lungs anymore. So they're able to kind of have a better like expansion of their thoracic cavity, opening those lungs up more. And it's been showing with these COVID patients pretty good response when it comes to increased SATs and increased oxygenation and things. So yeah, that's what proning is, and you don't want to keep them on there for very long. So there will be protocols at your guys' facilities or whatnot, but most of the time you want to do about, once they're in prone position, especially if they're intubated, for about anywhere from 8 to 16 hours, and then you flip them back over. But if they're not intubated, we usually have them go every couple of hours, just flip onto their sides, flip onto their belly, and then back to their back. Yeah, that was a good question.
All right, any other questions? You have just a couple more minutes. All right. All right, got a good info.
All right.
All righty.
Well, thank you guys for listening to my or attending my presentation and listening to me talk. And I just wanted to also thank the Eastern Oregon EMS guys for inviting me to come on here and talk. I really do appreciate it. I hope, yeah, I hope you guys get a little bit better knowledge now, and can kind of use that.
We convinced Derek that was going to be a small group, and you had about 213 people piped in.
Oh,
So,
wow.
yep.
I mean, it was small in the
job.
sense that I'm just here with just like 3 people in the room.
Yep, it was small. So we will log out. The link for Cody's session is in the chat box, and we will allow some time. He's going to have a 90-minute session to allow for more Q&A in talking about his journey with PTSD. So we're hoping to see you there.